Hanji.
We start.
Right. Thank you so much, sir. Hi, good afternoon, everyone. So today I'll be taking your block 2 for CFT mental disorders, and we will be discussing cognitive disorders, mental disorders, and substance use related disorders. Yesterday we were aware about the concept of normality, abnormality, DSM, ICD, and what do we mean by mental illness, mental health, what are the characteristics of a mentally healthy person. So now our focus is towards understanding the different kind of disorders and what are the signs and symptoms for those particular disorders and how do we cope with them. Are there any specific interventions which have been developed to cure, and whether certain disorders are really cured or not. So, to begin with, I'll start with cognitive disorders and we will discuss delirium, dementia, and amnestic disorders in cognitive. So, when I say cognitive disorders, it means something related to your mental processes, higher mental order processes, and that encompasses your orientation, your attention, memory, in fact, vocabulary, because language is also a part of cognitive only, then your calculation ability, and abstract thinking. So, the American Psychiatric Association, they included specific categories, or you can say the disorders, which are marked or known as cognitive disorders. Those are number one, delirium, DELIRIUM, then dementia, DEMENTIA, and amnestic disorders. Also, a certain general medical condition has been reported by American Psychiatric Association. So, under general medical conditions, we have mental disorders, and we will be studying mood disorders into this category. Mood disorders and schizophrenia. And the next is substance use related disorders. So, purposely, we will be dealing with alcoholism when we will be discussing this substance use disorders. Now, with most cognitive disorders, the brain is temporarily or permanently compromised, which means there is some kind of a deviation, a lesion, a traumatic incident, or something or the other has happened with your brain. So, what all those compromises include? Disturbed perceptions. If we are talking about the cognitive disorders, it means that the patient will have disturbed perception. Understanding the feeling or giving the meaning to the feeling is difficult for that person. ऐसा भी हो सकता है कि he see the similar face twice, thrice, but forgets the name of a person, right? Delusions, false perceptions again, paranoia, and aggressive and disruptive behaviors. Now, why aggressive and disruptive? Because the person feels frustrated or irritating when he's not able to recognize or recall whosoever the person or the object is. Now, the clients, they may sense that their thinking is impaired. Obviously, if we are talking about cognitive disorders, it means that your thinking is impaired. And so the person becomes frustrated, anxious, frightened. High emotions may also accompany this disordered state. So now when we say, if someone asks you that under what category or how will you say these cognitive disturbances are, like which of the following category they belong to? So if it is a, let's suppose if the person is suffering from diabetes, if any other physiological problem, so we will say that the person is coming into the category of physiological problems or diseases, right? So this cognitive disorders, they fall into the category called brain disease. There is some kind of disturbance, maybe a metabolic disturbance. I mean, you can say the response of the brain to systematic metabolic or cardiovascular system is disturbed. Now, there's unique reaction of the brain tissue and also the residual effects or the withdrawal from the exogenous substance. So, first, I'm going to discuss delirium and the population that comes or falls into this category. The maximum, you can say, the cases, the research report is the elderly population. Now, they say that delirium results from an acute disruption in the homeostasis of the brain. So, when the balance, the equilibrium is not maintained by the brain, there is some kind of disruption. So, we say it can be delirium. But of course, we have to see the DSM criteria. As we discussed in our previous lecture, that DSM 5, it is used as a Bible by psychiatrists before diagnosing or concluding that so and so patient is suffering from this disorder. Now, once the cause of disruption is eliminated or it subsides, then related cognitive deficits, they generally resolve in a few days. So it can be possible that it doesn't become a disorder. But at the same time, in contrast, it also results from primary brain pathology, which means if it is because of the brain pathology, it seems to be irreversible. That person will not get back to the original position. And then, if the case is chronic and, of course, progressive, so one can develop the maybe some other comorbid disorder related to delirium. For example, prompt oxygen treatment for dementia, we will be studying further. It stems from hypoxia and that can prevent further damage. So, if the patient is given the prompt treatment while he or she is suffering from such kind of a disorder, then there are chances that the patient can be cured. Now, delirium is characterized by the rapid onset of cognitive dysfunction and disrupted consciousness. Person is not able to understand where am I sitting or what am I doing, why I am here. So such cases are actually referred to as intensive care unit psychosis. It is also called as acute brain syndrome. Now, if we talk about the incidence and the prevalence of delirium, so we can say that 50% of elderly inpatients means in the hospitals, they suffer with this kind of a psychiatric syndrome. And then it is also associated with the increased morbidity, maybe during or after the hospitalization. Now, the prevalence of the repeated episodes of delirium, this acute confusion, if we say, and if we look into the research studies, they say certain nursing homes have reported that for those older than 75 years, people who are older than 75 years, the prevalence is 60%, more than 80% of the clients with the terminal illness. Now, enough of incidence and prevalence, as I have already said, that such kind of cognitive disorders, they are being seen to be highly prevalent among elderly population. What can be the cause? So the first thing that we target is the central nervous system. So when the central nervous system is impaired, it can induce delirium. Also, researchers have postulated different risk factors which are associated with delirium. So that can be a surgery, some kind of surgery done, metabolic disorders, drug withdrawal, toxicity secondary to drugs, or maybe the person is high on taking the drugs. These factors have also been associated with the development of such kind of disorder. Now, older adults, they are at significant risk for delirium, particularly those with pre-existing cognitive impairment. So people or the patients or the elderly population, if they are suffering, if they have certain kind of an existing cognitive impairment, maybe the results are worst in such population. And we all know that with aging, see, the neurons or the system that they become weak, and of course then they become vulnerable to such kind of conditions. Now this population is also at risk because of the number of medications, because this age comprises certain health issues, and then if a person is high on certain kind of doses, so can develop this delirium also, which means medications exert effects on the central nervous system and then are the frequent causes of delirium. Then, if any disturbance in any organ or the system is seen and it is disrupting the overall metabolism and the neurotransmission. So, what do we mean by neurotransmission? The synapses, right? Certain kind of biochemicals or the chemicals, they are being secreted in the synapses, transmitted to another neuron or axon. Dendrites are there to receive it. So, if the exchange of the neurotransmitters or the chemical processes is not done properly by the brain, there can be some kind of excitatory or inhibitory effect, which can again leads to cognitive decline. Certain infections and electrolyte or the fluid imbalances in the brain are also responsible or the contributing factors responsible for delirium. Now I will discuss the DSM criteria, how Diagnostic Statistical Manual has defined delirium. Now they say there are three salient features that comprises the main diagnostic criteria. One, disordered cognition. Two, attention deficit, not able to give attention, or they have some kind of concentration problems, not able to focus on a particular thing. And even the disturbed consciousness. So the cognition, the higher mental order process, is completely disorganized. Clients, they appear confused, they cannot reason, they don't have that knack for their logical thinking, not able to handle the complex task, and even they can't solve the problems. Also, along with the disorganized cognition, the speech at times is pressured, some kind of rambling or bizarre. The words are not being able to be understood. The speech can be incoherent, and at times it's all or it's nearly absent, you can say. Now, this impaired orientation, right? Not being able to understand where am I, or not able to even feel the spatial ability. So this may cause clients to confuse reality with imagery and the dream. So they are not able to find out the difference, or they're not being able to understand whether they are in their real states or they are dreaming. Also, along with these symptoms, they have suspiciousness, they are paranoid, and even persecutory delusions. Persecution, somebody is trying to kill them, follow them, or poison them for one or the other reason. Now, why is this happening? Why delusions, such kind of delusions and suspiciousness? Because the cognition is disturbed. So, when the cognition is disturbed, the perception, the attention, all these higher mental order processes, they are not working properly. They cannot reason. So, most of the time, they appear confused. Then the hallucinations. There's no stimuli present in the environment, but they believe that there is some kind of hallucinations, and then such kind of hallucinations induces anxiety or even the panic attacks. Now there are mood alterations also, and such kind of mood alterations can lead to great inability along with irritability, and at times they are very high on their mood, and at times they are very low. So dysphoria to euphoria. Then in delirium, there's also an inability to focus or shift their attention. So clients or the patients, they may have trouble attending to environmental stimuli. Usually they are being asked not to drive, not to remain alone at night, because they are disoriented to time, place and person. तो इनको अकेले नहीं छोड़ा जा सकता है. They need some kind of a support or a help 24 hours. Now, what are the interventions that we can use for delirium? Of course, the medical intervention, because without medicines, it's difficult to control the primary symptoms. So the medical interventions, they focus on the underlying cause. And if there is the case of low confusion or higher confusion, then certain kind of supplemental oxygen is seen significant to be given to the patients. If I talk about the environmental interventions, it means that we have to make the environment cordial, supportive for the client. So if they are hospitalized, we can provide them with a private room so that the staff can minimize the noxious and the confusing environmental stimuli. Because if they are in a general ward, so there happens to be some kind of disorientation. They're not able to understand even the family or the staff. So, there's a continuous coming and going. So the patient remains in a very haphazard manner. So to avoid that, it is preferred that we can provide them with a private room, then adequate lighting, of course, during the day and evening also. So such kind of environment, proper ventilation, they promotes the realistic environmental perceptions among the delirium patients. And if the patient need to use some kind of sensory aid, for example, eyeglasses, hearing aids, they must be given so that we provide them with the proper comfort zone. Now, apart from environmental interventions, there are certain cognitive and psychosocial interventions given to the delirium patients. So here comes the role of the staff members. Staff member, or if the home nurse is being provided, so they can try to direct some kind of activity and can reorient the focus of the client, right? Some kind of activity related to calendars, time, clocks, and then seasonal decorations. So some kind of ongoing interaction is very important. Then the therapeutic communication about the day's activity or the reassurance that if they have any kind of hallucination or delusions, they are just temporary and the person is going to get rid of it and will become healthy very soon, which means that we must reflect empathetic expression. So team members, they must keep the families informed about the treatment plans that they are giving, and also relatives, they need to understand and have patience about the biological basis for their behavior, that why are they behaving like this, why are they disoriented, why they seem to be confused. So if family support is there, patience is there, I think the time or the prognosis or the follow up is going to be better for such patients. Now coming to our next cognitive disorder, which is dementia. And this term is used for a syndrome characterized by several cognitive deficits that results from a general medical condition. It can be because of some use, or you can say abuse of a substance. So when I'm saying substance, can be alcohol or certain kind of a drug, or multiple biologic etiologies, causes. Now, although there are several types of, or you can say, or different forms of dementia that can affect the memory and cognition. So, I will be discussing dementia with Alzheimer, vascular dementia, and one or the other, one more disorder related to dementia. Now, all these kind of dementias or the clinical presentation of cognitive disorders, they are characterized by ongoing multiple cognitive deficits. So, ऐसा नहीं है कि कोई एक particular brain का portion is only responsible for this kind of a disorder. There can be different or multiple cognitive deficits. Memory impairment, which is enough to compromise the person's social and occupational functioning. And there is a certain kind of deterioration from the previous functioning. This is what DSM says. So, as consciousness decreases, clients cannot concentrate their attention span progressively. And therefore, their attention declines, they become distractible. They also become disoriented, and eventually, they can no longer recognize or identify familiar objects. This condition is named as agnosia, Agnosia. So, along with this category or symptom where they are no longer able to recognize or identify the familiar objects, clients with dementia, they also have difficulty finding the words they want to use in conversation. So कभी कभार ऐसा होता है कि बहुत देर तक they keep on mumbling or thinking that what word they have to use, but they are not able to find out. So that this kind of a condition is called aphasia. Aphasia. The previous one was agnosia. That is one, the person is not able to identify or recognize the familiar objects. Objects part of a, like even the, you can say a human face. देखा हुआ है पर ध्यान में याद नहीं आता है कि ये कौन है. And then you have difficulty finding the words that you want to use. That's called as aphasia. Then there is a strange thing seen in dementia that, after sunset, certain changes they become more pronounced. And so the name given to this particular condition is called as sundowning. Sundowning. Clients, after sunset, they become more irritable, suspicious, and misinterpret visual or auditory cues. Because of their diffused cognitive impairment, they may experience illusions and hallucinations. So, family members, they also report to the doctor or the concerned health worker that they have developed poor hygiene, the person suffering with this dementia, and they have also become defensive or pathetic. Dementia patients I'm talking about. So family members report. Then the patients, they may find that they cannot perform motor tasks, right? And simple basic daily activities like brushing the teeth, combing your hair. Why? Because, despite the intact motor function, they're still not able to do this. And such condition, because they have some kind of diffused orientation. Time and again, we are going to use this word diffused cognitive orientation. So, is the reason that they are not able to perform basic motor task, and such condition is known as apraxia. 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 So, we have agnosia in dementia, aphasia, sundowning, and apraxia. Now, the dementia of the Alzheimer's type. Clients in this, they have multiple cognitive deficits manifested by both impaired memory, and patient can have aphasia, apraxia, agnosia, or disturbed executive functioning. Then again, such kind of cognitive deficits will really affect or impair their social or occupational functioning and then represent a significant decline from the previous levels. Vascular dementia, the another kind of dementia. As I said, that we will be discussing certain categories under dementia. Now, in vascular dementia, again, the client develops multiple cognitive deficits. So, the symptoms or the condition that I'm talking about is as per the DSM criteria. It's not something that I have made it myself, but this is the proper professional criteria given by DSM, right? So, in vascular dementia also, there's impaired memory, and then one of the following features or the condition, that is aphasia, apraxia, agnosia, and along with that, impaired social or occupational functioning. So the difference can be in the population, the age range, and to certain extent, the duration period. Now, even in dementia, we need to provide medical and supportive interventions. The most important is that family caregivers, they need to know how to meet the physical needs of their loved ones as self-care capabilities diminish in the patient suffering from dementia. And the best thing is that some families, they are so much involved with their you can say patient or the person suffering from such condition that they need minimal information and guidance. I mean, they have one or the other kind of tangible assistance like home health aids they have, which are best or you can say used in a best manner to provide the assistance to the patients. Then psychosocial interventions, of course, they need support of their family, emotional support especially, to deal with their cognitive losses. Being empathetic, then family shall participate in the care planning and some kind of education also they can receive, which will be an additional aid along with the physical care that they render. Now, the third category of cognitive disorders, that's the amnestic disorders, AMNESTIC. Now, amnestic disorders, they include conditions with short-term memory or the loss as a hallmark. So, memory deterioration is so great that it prevents the clients from functioning at previous levels of social and occupational performance, and it also impair them from learning anything new. So, they're not able to learn any new information, and memory is highly deteriorated, especially the short-term memory. Now, they typically cannot recollect events as recent as 2 minutes earlier. That's why I said that it includes the conditions with the short-term deterioration. So, the short-term memory is that memory in which you can, if you have any kind of a material, you can immediately retrieve back to your conscious level. So, patients suffering with amnesia, they cannot recollect as recent as 2 minutes earlier event. They may have difficulty recalling the events or knowledge that they formerly knew. Now, this clients, they have become adapt to certain kind of confabulation to hide the deficits. उनको ऐसे लगता है कि they remember everything, but then why? Because if they express this concern that they are not able to recall, then again certain kind of sadness on their part they feel, and again they can become hostile or irritable. Now, if in amnesia there is a brain damage, so this brain damage can leave the client disoriented to time and place to some degree, but not so to the personhood. I mean, still the person can reorient. Now, they frequently adopt to the blandness of affect. Blandness of affect, emotional disorientation. They're not able to understand which emotion to be reflected at which time. Now, enough of cognitive disorders discussed. I'll shift your focus to the mood disorders. So, in DSM-5, according to DSM-5, the mood disorders, they are divided into two main categories. One is depressive and the other is the bipolar. And of the depressive disorders, major depressive disorder and persistent depressive disorder have been the most thoroughly researched. We will be discussing bipolar also, but अगर हम depressive disorders की बात करते हैं, so the two kind of depressive disorders that have been thoroughly researched are major depressive disorder. It's also represented as capital M, capital D, like MDD, and persistent depressive disorder. Now, this bipolar and related disorders. I'm just gonna go through the kind of disorders that we are going to study, a quick glance on them. If you wish, you can write them. So, in bipolar and related disorders, we have bipolar 1 disorder, bipolar 2 disorder, cyclothymic disorder, cyclothymic, CYCLOTHYMIC. Then substance or medication induced bipolar and related disorder. So these are the categories actually given by DSM-5. There are certain changes made. So this we have with the latest DSM-5. And then after substance or medication induced bipolar related disorders, we have related disorders due to another medical condition. So there can be a category which is not exactly bipolar, but then a person is diagnosed with related disorder due to another medical condition. Now, the depressive disorders. The kind of depressive disorders we have, number one, disruptive mood dysregulation. Number two, disorder, major depressive disorder. The first was disruptive mood dysregulation. Second is major depressive disorder. Third is dysthemia. Nowadays, dysthemia is called as single and recurrent episodes or persistent depressive disorder. Now we don't no more call it as dysthemia. Then premenstrual dysphoric disorder, substance or medication induced depressive disorder, and few disorders that are due to another medical condition. Now, among the bipolar disorders, bipolar 1 disorder has received the most empirical attention. जैसे मैंने आपको depressive disorders में बताए कि जो दो MDD and persistent depressive disorder को thoroughly research किया गया है, bipolar में bipolar 1 maximum empirical attention has been given, and 2 has always been a distant choice. Now, in DSM-5, I would want to tell you there is a new diagnosis जिसका मैंने पीछे नाम लिया था अभी, and that is premenstrual dysphoric disorder and disruptive mood dysregulation disorder. So this was a new disorder included in DSM-5. Now, what are the characteristics or what are the signs and symptoms according to DSM criteria for this major depressive disorder, MDD? Now, the diagnosis says that MDD requires an experience of at least one major depressive episode. Then 5 of 9 symptoms, 9 में से कोई 5 symptoms होने जरूरी हैं before we diagnose a person suffering with depressing mood. Other symptoms can be feelings of guilt, low energy, disturbances in sleep, poor appetite, and psychomotor activity. Now, psychomotor activity is actually retarded because the person is in depression phase. But at times, it has been reported by certain clients that their psychomotor activity is intact. It never changes. Now, these symptoms, जो मैंने अभी बोले हैं, feelings of guilt, low energy, disturbances in sleep, they must be present most of the day, every day, for at least 3 weeks. And then again, these symptoms must impair functioning or cause clinically significant distress. Only then person can be diagnosed with MDD. Now, if I talk about the persistent depressive disorder, now this disorder requires the constellation of at least 3 of 7 symptoms. And one of the symptom is that the mood is depressed most of the time in persistent depressive disorder. Along with that, person has low self-esteem, poor concentration, feelings of hopelessness, and these symptoms are present for at least 2 years with no 2 month period when the individual was normal or without the presence of any symptoms as such. Then premenstrual dysphoric disorder. So in this category, at least 5 mood disorder symptoms, you can say, in the final week before the onset of menses must be experienced by a woman. So one of the symptoms can be irritability, depressed, anxious mood, lethargic, disturbances in sleep, or appetite. Disruptive mood dysregulation. Now, the criteria for disruptive mood dysregulation is, now this requires the presence of temper outburst that emerge before the age of 18 years, 18 years. Now, these outbursts are displayed verbally in their behavior, and these symptoms must occur 3 or more times per week. Now, there are also certain disorders that are not mood disorders, but then they are included into this category. As you remember, initially when I was reading the type of disorders that fall into mood disorders or bipolar, so there was a term that I used, related disorder. So those related disorders can be loss, grief. Now, grief is a psychological process, in like when you go through the, like following the death of a loved one, there can be numbing, disbelief, disorganization, despair. So all these problems, they are not actually called as disorders, but of course they come or they fall into this category only. Then there's also a term called as postpartum blues, POSTPARTUM, postpartum blues. So this occurs in new mothers following the birth of a child. And symptoms are emotional lability, crying easily, irritability. And what can be the causes for postpartum blues? Like hormonal readjustments, there's lack of social support from the family, or maybe the history of depression. Dysthemic disorder. So a depressed mood for most of the day, for at least 2 years, 1 year for children and adolescents. Then, as I said, that following symptoms are required, that can be poor appetite, hypersomnia. You see, most of the symptoms, they are similar. I mean, they are related one way or the other. Of course, जो person depressed phase में होगा, sad होगा, so of course उसका energy level भी low होगा. अच्छा, भूख नहीं भी लग सकती है और ओवर ईटिंग भी हो सकती है, नींद नहीं भी आ सकती और बहुत ज़्यादा भी आ सकती है. Then feeling of hopelessness is also accompanied along with this disturbance. Now I will shift to bipolar 1 disorder. So in bipolar 1 disorder, the patient must meet the criteria for a manic or mixed episode. Manic, when you are high on your affect. So what is manic episode or mixed episode? So I'll explain manic episode. Manic episode is defined by a period of at least 1 week, or if not less, there's certain kind of hospitalization during that week, 1 week at least. And during that time, your mood is elevated, can be irritable also. It is accompanied by an increase in goal directed activity, very high on energy. But at the same time, there is some kind of significant impairment because for normal things to go on, you have to be balanced. High or too low. I mean, extreme is always bad. So you cannot say that the person is having high mood or feeling very good. He's not euphoric actually, but somewhere or the other, impairing the normal day-to-day activity. Mixed episodes, they involve either experiencing manic, जिसको अभी डिफाइन किया हमने, या फिर डिप्रेसिव सिम्टम्स जिसको हम पीछे अभी डिफाइन करते आ रहे हैं. So they are experienced concurrently or in a rapid sequence. Manic, mixed, manic, mixed. Bipolar 2 disorder. Now in bipolar 2 disorder, the person must meet criteria for hypomanic, Hypomanic, or mixed hypomanic episode. Now what is hypomanic episode? See, this episode is milder and more transient than a manic episode. वहाँ हम एक हफ्ते की हॉस्पिटलाइजेशन मिनिमल एक्सपेक्ट कर रहे थे. इट इज डिफाइंड, दिस हाइपोमेनिक एपिसोड इज डिफाइंड एज अ पीरियड ऑफ एट लीस्ट 4 days during which the mood is expansive, alleviated, and accompanied by an increase in goal directed activity. So these episodes are also distinguished from manic episodes in that although they represent a change in functioning, but the disturbance is not severe, जितना manic episodes में हम देख रहे हैं. So ये कोई ज़्यादा marked impairment नहीं लेके आता normal functioning में. Then cyclothemic. This disorder is an additional bipolar disorder category that applies to individuals with a chronic duration of 2 years of hypomanic और डिप्रेसिव, और नहीं एंड दोनों, क्योंकि साइक्लो है साइकिल्स. सो इन साइकिल्स फॉर 2 years the person is experiencing hypomanic symptoms or depressive symptoms, but at the same time they do not meet the full criteria for either a hypomanic or a major depressive episode. So वो साइकिल्स में होके कोलैप्स होता जाता है, फुल ब्लोन डिसऑर्डर नहीं बनता है. Now, these bipolar disorders, they typically emerge in late adolescence or young adulthood with mean age of like 18 to 20 years for bipolar 1 and 2. And if we talk about you can say the predictors of bipolar disorder, they have reported a list of factors, out of which lower education level, unemployment, or a history of divorce, they serve as the predictors for bipolar disorder. Even suicide or suicidality is a common symptom of the mood disorders. Like approximately 40% of those, if they are diagnosed with a major depressive disorder, so they report suicidal thoughts or the behaviors linked with that suicide. Now I will discuss schizophrenia, psychosis. Now, schizophrenia has been recognized as a psychiatric disorder, and it was described in 1878 as dementia praecox, right? अब स्किज़ोफ्रेनिया में भी हमारा कॉग्निशन जो है वो इंटैक्ट नहीं रहता है, बट ज़रूरी नहीं है हर टाइप में ऐसा हो, डिपेंड्स अपॉन द सिविरिटी. So this name dementia praecox, dementia DEMENTIA, praecox PRAECOX. This name was given by Emil Kraepelin, EMIL Kraepelin, KRAEPELIN. So this schizophrenia is a premature deterioration of the brain. And now in DSM-5, we don't go through the types of schizophrenia because it was observed that one way or the other, symptoms were interrelated. And it was really difficult to um, put a patient into one or the other type. So if a person is suffering from paranoia, there were certain symptoms, positive or the negative symptoms, seen of like hebephrenic type or catatonic type. But then from your syllabus point of view, we somehow discuss these types also. But nowadays in DSM-5, we just discuss the etiology and the treatment part. Now, you see, Emil Kraepelin, he classified patients presenting with simple dementia praecox as some kind of, they are exhibiting some kind of slow social decline. एक तरह से withdrawal होता है from the reality. Then they were also classified as having paranoid dementia, which means higher amount of fear or the persecutory delusions, even the delusion of grandeur, that if you are wearing white, something today, so it is like God has given you a signal, or if some song is being played, so it is that God has sent a message for you, or if someone is looking at you, then that person wants to kill you, or the food is being served, then the persecutory delusion that they want to kill me. अगर कोई दो लोग हंस रहे हैं आपके सामने तो they are laughing on you या आपकी बात करके. Now this hebephrenic type, HEBEPHRENIC type. Now this was described as being silly. And finally the catatonic, they were those with increased motor symptoms, increased muscle tone and perseverance for posture, which means कि अगर आपको एक posture में, see, in schizophrenia you have to be hospitalized, the patient has to be hospitalized, you can't cure that person at home because of the some kind of violent behavior they exhibit, so we have to hospitalize them. So this, if a person is diagnosed with catatonic, they have the increased motor symptoms, which means they are going to be in the same posture for, if I'm not wrong, for hours, right? They have that, they maintain that posture. Then in 1908, Eugen Bleuler, EUGEN, Bleuler, BLEULER. So he found that schizophrenia was less definite or less definitive than Kraepelin believed. And then it could range from severe to mild cases also. And so Bleuler coined the term schizophrenia, which literally means the split of your mind. So in paranoid schizophrenia, there are paranoid symptoms, suspiciousness, delusions, hallucinations, you hear voices, and it's a lifelong disorder. But with proper treatment, a person with this illness can attain a higher quality of life. Then there are delusions of grandeur in paranoid schizophrenia. Yeah, for example, the belief that you can fly, right? That you are famous or you have a relationship with a famous person. Now, hebephrenic is also called as disorganized. and they include the negative symptoms. That is, they don't have any interest in any activity, along with hallucinations and delusions. And hallucinations are more severe, and the range keeps on increasing. The range of symptoms are increasing as per the type we are discussing. But then, with certain kind of treatment or the remedial measures, as I said, that the initial types can be cured. But if we talk about the catatonic or the hebephrenic or the residual type, the treatment is effective, but we cannot say that person will get back to the normal life. But then certain programs like token economy programs, then pharmacology help, has recently shown to be effective with schizophrenic patients also. Now, substance use disorders. It affects both the gender and all races, right? Substance use is actually the addiction. So, this addiction is a state of chronic intoxication, and it is produced by repeated consumption of a drug. An empowering desire or need to continue taking the drug and to obtain it by any means. You want it, you want it. And then a tendency to increase the dose, a psychological, a psychic, and generally a physical dependence on the effects of the drug. And then detrimental effect on the individual and society. Now, the DSM, both in its revision, irrespective of the versions, they avoid the term addiction, preferring instead to use the diagnosis of substance abuse. That's why now we call it as substance abuse and dependence. And collectively, if we have to define it, we will call it substance use disorders. Now, this dependence syndrome, hai kya ye? This dependence syndrome is a cluster of physiological, behavioral, and cognitive phenomenon in which the use of substance takes on much higher priority for a given individual that the other behaviors that once had greater values. So there's a strong desire or a compulsion to consume the substance, right? Withdrawal state when the substance is reduced, tolerance, there's sense of preoccupation, and persistent substance use leads to harmful consequences. Now, why is it difficult to quit substance? क्यों ऐसा क्यों है? Why? Because initially the substance taken was giving the pleasure effect. Now, this regular long-term use leads to dependence. Then you built up the tolerance for such kind of dependence, and then when you stop taking the substance, it produces withdrawal symptoms. So, to avoid the withdrawal symptoms, you have to take the dose again. Now, what can be the causes of substance use? It can be psychological, like drug or the substance has the calming effect. It can be because of stress. It can be due to some socio-cultural factor, environmental factor, environmental like the parent is alcoholic, biological, of course, genetic, or some kind of psychiatric illness. So the commonly used substances are nicotine, alcohol, cannabis, opium, benzodiazepines, and other stimulants. Then we have alcohol related or alcohol use disorders. What kind of alcoholic beverages? Beer, wine, spirits. So these alcohol beverages with low concentration of alcohol, we all know they are produced by fermentation of sugar or starch, whereas that with the higher concentration, they are produced by the fermentation followed by the distillation. So the scenario is, I'll be ending up my lecture now, but before I end up, I want to tell you that alcohol contributes to 1.8 million deaths each year, and this is worldwide ratio. And in US, 22,000 deaths and 2 million non-fatal injuries because of this alcohol. And if we talk about the India, the data available is just the tip of the iceberg. After nicotine, I want to tell you, most commonly psychotropic substance of use in India, and still you say the percentage is increasing as the stress tolerance reduces, the person is becoming more and more vulnerable for taking such kind of substance use disorders. So that's it for today.
थैंक यू मैम। सभी विद्यार्थियों से आग्रह है कि चैट बॉक्स में अपने नाम और अनुमान नंबर के साथ अपनी उपस्थिति दर्ज कराएं। ये प्रत्येक मीटिंग में ऐसे रहेगा, आप अपना नाम और अनुमान नंबर चैट बॉक्स में शेयर कर देंगे। ये जस्ट अटेंडेंस का एक नया तरीका सोचा है, जिससे कि हमें ये पता लगे कि ऑनलाइन कक्षा में कितने विद्यार्थी पार्टिसिपेट होते हैं।
हेलो,
आप कोई प्रश्न है तो आप बताइए।
हेलो
जी बोलिए।
हेलो,
हाँ, मेरा नाम अलका बंसल है। हेलो, कैन यू हियर मी? हेलो,
यस अलका जी बोलिए।
हाँ, मैं सर दिल्ली से बात कर रही हूँ, RC3 से जुड़ी हुई हूँ, भारती कॉलेज से। मैं आपसे सर ये जानना चाहती हूँ कि ये जो रिकॉर्डिंग है, ये अगर हम जैसे हमारी कभी मिस हो जाती तो हम क्या इस रिकॉर्डिंग को यूज कर सकते हैं या हमारे लिए अवेलेबल होगी क्या ये?
अलका जी बिल्कुल, सभी वीडियोस हमारे रीजन सेंटर के पेज के ऊपर, फेसबुक पेज के ऊपर उपलब्ध हैं, और जो हमारे रीजन सेंटर चंडीगढ़ की वेबसाइट है उसके स्टूडेंट जोन में इसका एक लिंक भी है।
अच्छा, तो आप मुझे यहाँ पे लिख के शेयर कर सकते हैं, क्योंकि ऐसी बहुत सारी चीजें हैं जो कि हमारे यहाँ पे सेंटर में भी जो है बहुत सारे बच्चे हैं, स्टूडेंट्स हैं, तो वो भी इसका लाभ उठा सकें। तो आप इसका लिंक शेयर कर सकते हैं सर?
निश्चित रूप से अभी आपको लिंक मिल जाएगा।
ठीक है, थैंक यू सो मच सर।
चैट बॉक्स में होगा लिंक।
ठीक है सर, थैंक यू सो मच।
अच्छा, और सबसे जो स्टूडेंट्स हैं उनसे क्या सब नए एडमिशन जो है, लिंक इज ओपन फॉर द न्यू एडमिशन फॉर जुलाई 2020 सेशन। So I would request all the students, they may disseminate this information to their known persons or in their neighborhood, so that some other persons can avail the opportunity, because in this period the distance mode of education is the best option for all the concerned. Thank you very much. Thank you Tejpal ji, and thank you madam for taking
क्वेरी है सर, एक और बात पूछी थी कि हमारे एग्जाम्स का कब तक एग्जाम होने के चांसेस हैं?
अभी मैडम इस पे कोई डिसीजन जो हायर अथॉरिटीज हैं दिल्ली में वो लेंगी, बट इट विल बी डिस्प्लेड ऑन द वेबसाइट, एंड दोज हु हैव सबमिटेड द फॉर्म, द मैसेज विल बी given to them from headquarter Delhi. So most probably you just be in touch on the new website. It will be in the mid-July or after that. Before 15 days it will be announced.
थैंक यू सो मच सर।
क्योंकि विद्यार्थी हम लोग 17 के करीब हैं, लेकिन अभी लगता है कि 8 विद्यार्थियों ने अपना एनरोलमेंट नंबर और नेम शेयर किया है। तो प्लीज जिनके रह गए हैं वो भी अपना नेम एंड एनरोलमेंट नंबर शेयर करें।
तेजपाल जी मेरी मेल भी चेक कर लीजिएगा अपनी मेल में।
जी
कल भेजी थी एक।
हो गया रुक सर।
ओके वो बड़े परेशान। थैंक यू एवरीवन।